Welcome, my friends, to the Bob and Brad podcast. My name is Mike Keenitz, and I'm a PT assistant. Today, I am interviewing RT Hill and Niraj Vora from the Stride Shop. Both are physical therapists, and they own a running clinic in Baton Rouge and New Orleans, Louisiana. So we are going to talk about different running injuries and how to work through them and different exercises you can try to fix these problems. So without further ado, here are the gentlemen from the Stride Shop. We will go on to heel pain when running. So heel pain is very common among runners and even non-runners. So what is your approach to working with someone who has heel pain?
I'll jump in there. So I think first thing to kind of consider and be aware of is that not all heel pain is the same deal, right? There's a lot of differential diagnosis that can happen in that area. For instance, insertional Achilles, right? So where the Achilles tendon actually inserts into the bone, that's a different treatment and different approach than someone who has like a plantar fasciitis or a fat pad displacement or like a retrocalcaneal like bursitis or something like that, right? So the approach needs to be individualized. And another one of those that I feel like gets kind of lumped into that heel pain or Achilles tendonitis is, again, is it an insertional or is it higher up, more in the tendon or the musculotendinous junction? We mentioned before, the way that you treat a bone injury is very different from the way that you would treat a tendon or muscle, right? So in one of those diagnoses, when it's more in the tissue, you want to load that. It needs that tension across it in order to build up more resiliency and build up. If it's where it's on the bone, right, we're trying to unload that a little bit and just give it a breather so it can go through its inflammatory cycle, and then you can progressively get back into it, right? So the initial approach is, again, it's not all of it's the same. So you got to work on your skills, and seeing multiple people with different types of heel pain helps with that kind of process instead of just putting it under an umbrella term. In terms of how we then go into the differential diagnosis and some of the objective things that we look at, similar to stuff you see with shin splints, honestly, a lot of, do you have toe dexterity and splay? What's your ability to activate the digitorum brevis musculature? How's your peroneal strength? If I just have someone standing there, and make them actually bring their attention to the bottom of your feet, like where is your weight distributed? Because very few people that come into the clinic, if I say, where's your weight on the bottom of your foot right now? They're like, bottom of the foot. And you have them start thinking, all right, well, is it on the heel? Is it on the back portion of the heel? Or are you hanging out towards the ball of the foot? Are you hanging on the right side? And very few people, I think, have this volitional awareness of like, where am I actually putting my weight on a day-to-day basis while I'm just standing for hours at a time, right? So part of it is bringing some attention to that kind of thing, and then we're going to test it. I want to know what you can do. Can you go a double leg heel raise? If you can do that, fantastic. Can you do a single leg heel raise from a flat surface? Fantastic. If you're able to do that, well, then let's put you in a little bit of a deficit and see if you can activate and that tissue can tolerate it when it's got a little more force on it. If you start going through those criteria based, right, and you can prove at different segments of rehab or during an evaluation that you're able to do those kind of things, then we kind of know, one, how serious is it? Where is a lot of that pain potentially coming from? And then we have a good way of gauging, well, is it appropriate for you to actually get back to running, right? If you're not able to do a single leg heel raise, it's definitely not fair for me to be like, well, go try a quarter mile and see how you feel at the end of it, right? So that goes into us, and I'm sure we'll get into it at some point, like what our criteria is for someone to get back to running. For me, being able to do a series of some single leg heel raises is an important part of that.
Sure. Is there any? It's too individualistic, I would say, to recommend anything, at home for people to try. I mean, besides the test you just discussed.
Well, I think that there are things that you can try, but there are things that you probably shouldn't do. And I think traditionally, in a lot of clinics, and I've been in these clinics and I've done this in the past, it's like everybody with pain on the bottom of their foot is treated for plantar fasciitis. You roll it out, you do some toe curls on a towel, or you pick up some marble balls and drop them in a cup, and and then you get massaged, and that's and we stretch our calves, and we hope that
Stretching,
treats,
right?
yeah, we'd hope that treats your heel pain. And in fact, kind of grabbing a towel or picking up marbles with your toes is kind of doing the opposite of what it kind of reinforces a lot of the patterns that probably led to heel pain. You're starting to use those long toe flexors that run up into your shin and cause shin splints in a lot of cases. When in reality, we should really be training to use those short toe flexors of your foot. And if massage and stretching feels good, I think it's great. I don't see any problem with it. But I think we treat plantar foot pain or heel pain way differently than we do in the rest of the body. We don't just hope that we stretch something and it kind of goes away over time. I think we need to treat it just like we would a quadricep strain, right? Like after symptoms are calmed, we want to make sure that quadricep is really strong. And so how do you make the bottom of your foot really strong? And so, the exercises that we start to have people do are, again, one, start with the toe yoga. Two, we can add a band to the lesser four toes and have people just push down with their band. They don't grip with it, but if they can push down from the proximal joint, then you start activating the flexor digitorum brevis, and you get you almost feel this crampy sensation right in the middle of your foot. It kind of tracks along the bottom of your foot the same way the plantar fascia does. And so we have to reinforce it. And then if people can tolerate it, like RT said, we get into those single leg activities, but we cue really, really hard that you're going to use your big toe. You're not going to grip at the ground and try to find stability from your lesser toes. You're going to keep that foot tripod, we call it, under the little toe with all the big toe and the heel, and have some awareness, like RT said, of what your foot is doing, as opposed to just trying to pick things up with your toes and stretch things.
And stretching it.
Yeah. Do you guys have people, as long as it's not acute, do you have them try to spend time maybe being barefoot or less cushioning shoes just to naturally strengthen their foot up then?
Yeah, absolutely. The way that I tend to present this to clients that come in is, if you think of the bottom of your foot as a antenna, it tells your brain, hey, this is the surface that I'm on. This is the angle our foot's turning at. This is the way. Here's how the support is at the bottom of our foot. The stronger that signal is, the better, right? And the best way to get that is to get as many pressure points, as many tactile points on the bottom of that foot as possible, because that's more data that the brain has to use to develop a connection between the head and the foot. If you're in a shoe that has a really high stack height, right, that space from the ground to the bottom of the foot has this kind of dampened surface that it has to make its way through. So you're kind of putting the brain and the foot at a little bit of a disadvantage at that point. So for most of the people that I treat, we do a lot of the stuff barefoot. So I kind of had, when I first started running again during COVID, like everyone else. Yeah.
I was having some kind of, it never bothered me besides when I was running. And then later on, I started getting into more flat shoes and minimalistic, and I don't have the problem at all anymore. I was lucky it wasn't ever terrible, but that's just what I didn't want away naturally. And for our listeners, I think that was a dog in the background, not some.
Sorry.
That's fine. At first, I was like, "What is that?" It was just a dog. Don't worry.
Just a dog. No, I think it's not that there's one way to treat heel pain, but I think that there are bad ways to treat heel pain, and there are also, we see clients all the time where people have plantar fasciitis, and their provider or whomever they go to see tells them, you should never walk barefoot because it'll hurt too much, or you can't wear flip flops ever. And like you said, maybe in an acute case, we aren't just telling people to go walk on the beach barefoot when they've got plantar fasciitis, but we're not in the business of having people avoid things for the rest of their life for fear of having their pain return. If we can do things the right way, you should be able to do all those things.
You guys want to mention your website and where people can find you on social media quick before we get too in depth here?
Sure. Our website is thestrideshop.com. We've got blogs and some free resources and a newsletter that we that we think is cool. And we've also got an online course called video series called Building a Resilient Runner that we think stuffs a ton of information into some 10-minute segments that can be helpful for runners of all abilities. And then social media, we are at The Stride Shop on Instagram and The Stride Shop on Facebook.